What's up, my average med students? Welcome back to another episode. Today we're going to be covering Psychiatry from the TZANKI Step 2 deck. If you haven't already done so, please hit the subscribe button and press the bell icon to be notified of future posts. Happy studying.
Which demographic has an especially high risk of suicide immediately following the initiation of pharmacotherapy for major depressive disorder? Young adults aged 18 to 24 have a higher risk of suicide when they start taking medicine for MDD. However, the risk of suicide associated with untreated MDD outweighs the risk associated with initiating pharmacotherapy. Therefore, it is important to closely monitor patients in this demographic. Which class of antidepressants are contraindicated with tyramine-containing foods such as cheese, red wine, and cured foods? Monoamine oxidase inhibitors should not be taken with tyramine-containing foods as they can lead to hypertensive crisis. Which tricyclic antidepressant is used to treat obsessive-compulsive disorder? Clomipramine, also known as anafranil, is the only tricyclic antidepressant that can be used to treat OCD. However, selective serotonin reuptake inhibitors are considered first-line treatment for OCD. Which atypical heterocyclic antidepressant is especially associated with sedation? Trazodone, also known as Deseril, is associated with sedation. Therefore, it may be used in combination with another antidepressant in depressed patients with insomnia. What is rapid cycling bipolar I disorder and how is it treated? Rapid cycling bipolar I disorder is a subtype of bipolar I disorder that involves at least 4 mood episodes, major depressive episode, mania, hypomania, or mixed episode, in a 12-month period. This subtype is associated with poor prognosis and affects around 20% of bipolar I disorder patients. Treatment with valproate, for example, is one of the treatment options for this subtype. How is loosening of associations different from word salad? Loosening of associations is a psychiatric term used to describe the flow of thought with random shifting of ideas from one subject to another. Word salad is a type of disorganized speech in which a sequence of words is spoken that have no logical connection. The words do not belong together and are often difficult to understand. 7. What is the key difference between schizophrenic delusions and delusions in delusional disorder? Schizophrenic delusions are bizarre versus non-bizarre plausible. 8. Grandiose delusional disorder is a subtype of delusional disorder that involves delusions that the individual possesses exaggerated power, money, or knowledge. 9. Erotomanic delusional disorder is a subtype of delusional disorder that involves delusions that another person, usually of higher status, is in love with the individual. 10. Hyperprolactinemia is a side effect of typical antipsychotics that can present with amenorrhea, galactorrhea, and gynecomastia. As always with these symptoms, suspect and rule out a pituitary tumor first. 11. What is the difference between obsessive-compulsive disorder OCD and obsessive-compulsive personality disorder OCPD? OCPD is egosyntonic and lacks separate obsessions and compulsions. Egodystonic, patients know that their behavior is problematic. Egosyntonic, patients are unaware that their behavior is problematic. For example, it is a part of their personality, they have little insight. 12. What is the diagnostic criteria of post-traumatic stress disorder PTSD? Symptoms must be present for greater than 1 month. Symptoms include re-experiencing of traumatic events through intrusive thoughts, flashbacks, and nightmares can be confused with auditory, visual hallucinations. Avoidance of stimuli associated with the trauma. Numbing of responsiveness through anhedonia, amnesia, restricted affect or detachment, increased arousal through hypervigilance, insomnia, increased startle response. Poor concentration and irritability also includes survivor guilt, personality changes, dissociation, aggression, depression, substance abuse, and suicidality. 13. Acute post-traumatic stress disorder PTSD is a subtype of post-traumatic stress disorder PTSD that involves symptoms present for 3 days to 1 month following greater than one traumatic event. 14. Acute stress disorder is an anxiety disorder that presents similarly to post-traumatic stress disorder PTSD but involves symptoms that last 3 days to 1 month. 15. What is the first-line pharmacotherapy for post-traumatic stress disorder PTSD? SSRI or SNRI, prazosin, to improve sleep. Higher than normal doses of antidepressants are required. Buspirone can be helpful. The second line are anxiolytics, beta blockers, and plus or minus partial beta agonists. 16. Borderline personality disorder is a type of personality disorder that involves marked impulsivity, an unstable sense of self, relationships, and recurrent suicidal ideation. There is an inability to control mood lability and chronic feelings of emptiness. 17. Atomoxetine, Strattera, is a non-stimulant drug for attention deficit hyperactivity disorder, ADHD, that acts by inhibiting 5-HT and sodium reuptake. Second-line therapy for ADHD, no potential for addiction and favorable side effect profile. BLACKBOX warning, suicide risk in kids. 18. What is the diagnostic criteria for adjustment disorder? Must arise within 3 months of the stressor, and unless it is a chronic stressor, it must resolve within 6 months. Axis 1 or bereavement criteria must not be met in order for this diagnosis to be given. Bereavement is when someone has died. Axis 1 refers to the primary diagnosis or primary condition that a person is experiencing. This can include various mental health disorders such as depression, anxiety disorders, bipolar disorder, schizophrenia, and PTSD. 19. Label indifference is a feature of conversion disorder that involves the patient showing a characteristic lack of concern. 20. Which SNRI is typically avoided in hypertensive patients? Venlafaxine can increase diastolic BP. 21. Which typical antipsychotic is associated with a purple-gray metallic rash over sun-exposed areas and jaundice? Chlorpromazine. 22. Which atypical antipsychotic has the highest risk of EPS and hyperprolactinemia? Risperidone, Risperdal. FGA and Risperidone atypical are the antipsychotics with the highest potential for increasing prolactin. 23. What is the antipsychotic drug of choice for anorexia nervosa after CBT and nutritional rehabilitation fails? Olanzapine. 24. What head CT, MRI findings are associated with Huntington disease? Caudate nucleus atrophy. 25. What is the treatment of choice in a depressed patient with poor appetite, weight loss, or insomnia? Mirtazapine increases appetite, weight gain, and sedation. Trazodone also helps with insomnia, but not weight gain. 26. Body dysmorphic disorder is the diagnosis when patients have an imagined or slight defect in appearance, causing distress and impaired ability to function in a social or occupational setting. What's the treatment? CBT, SSRIs. If the only concern is body shape and weight, anorexia nervosa is the more accurate diagnosis. If the only concern is sex characteristics, gender identity disorder is the more accurate diagnosis. Flaws are mild or not observable by others. 27. What is the only illicit drug that causes vertical nystagmus? PCP can also cause horizontal and rotatory nystagmus. 28. A female patient presents with patchy hair loss. Her past medical history is significant for OCD. Physical exam reveals patchy alopecia and a head full of hair at different lengths. What is the most likely diagnosis? Trichotillomania. 29. A patient is diagnosed with trichotillomania. Which GI disorder should you worry about? SBO, secondary to Bez or eating hair. 30. The first-line treatment of choice for adjustment disorder is psychodynamic psychotherapy or brief cognitive psychotherapy. 31. Sublimation is a mature ego defense that involves replacing an unacceptable wish with a course of action that is similar to the wish, but does not conflict with one's value system. An aggressive person who channels their aggression into sports. 32. What part of the brain is affected by Alzheimer's? Nucleus basalis of Maynard. The hippocampus is also damaged. You will see cortical atrophy on imaging. 33. High-dose glucocorticoids may cause glucocorticoid-induced psychosis, for example, hypomania, confusion, hallucinations. 34. First-generation H1 receptor antagonists may acutely suppress the extrapyramidal side effects like acute dystonia associated with certain antipsychotic drugs. For example, acute dystonia, drug-induced Parkinsonism, antimuscarinic effects re-establish dopaminergic-cholinergic balance. 35. Indirect sympathomimetics. Atomoxetine is a NET inhibitor used to treat ADHD. Second-line therapy, no potential for addiction. 36. Indirect sympathomimetics, modafinil, is a stimulant used to treat narcolepsy. Fewer adverse effects compared to amphetamines. 37. Wine and aged cheese contain the sympathomimetic tyramine, which is metabolized by the enzyme monoamine oxidase and may cause hypertensive crisis in patients on MAO inhibitors. 38. Visual hallucinations are more commonly a feature of medical illness than psychiatric illness, psychiatric or medical. For example, drug intoxication. 40. Auditory hallucinations are more commonly a feature of psychiatric illness than medical illness. For example, schizophrenia. 42. Delirium tremens, secondary to alcohol withdrawal, typically occurs after 48 to 96 hours. For example, fever, disorientation, severe agitation. 44. Benzodiazepines may be used to treat generalized anxiety disorder and panic disorder until SSRIs and SNRIs take effect. Benzodiazepines can be used temporarily to treat anxiety while waiting for SSRIs, SNRs take effect. Never used for long-term management, increased risk of benzodependence. 45. Flumazenil can precipitate seizures by causing acute benzodiazepine withdrawal. 46. Methadone is a long-acting partial receptor agonist used to treat opioid withdrawal symptoms. Naltrexone is used to prevent relapse in opioid use disorder but only in absence of acute withdrawal symptoms. Methadone is used for opioid withdrawal and naloxone is used for opioid overdose. 48. Naltrexone is a partial opioid antagonist that helps maintain abstinence in opioid addicts once detoxified. Naltrexone, no relapse. 49. Naltrexone is a partial opioid antagonist that helps reduce cravings for alcohol and nicotine. 50. In addition to typical opioid adverse effects, tramadol also may cause decreased seizure threshold and serotonin syndrome. Other causes include MAOIs, SSRIs, SNRIs, TCAS, tramadol, ondansetron, triptans, MDMA, dextromethorphan. 51. Dantrolene is a muscle relaxant that is used to treat malignant hyperthermia and neuroleptic malignant syndrome. 53. What is the most serious adverse effect associated with lamotrigine use? Stevens-Johnson syndrome. Mild rash develops in up to 10%. Lamotrigine is also used as a mood stabilizer in bipolar disorder. Discontinue at first sign of rash, thus must be titrated slowly. 55. Carbidopa exacerbates the neuropsychiatric side effects of levodopa. 56. Does Parkinson's dementia develop before or after the diagnosis of Parkinson's disease? Dementia after the diagnosis of Parkinson's disease. Dementia with Lewy bodies. Dementia develops before or at same time as Parkinsonism. Parkinson disease. Parkinsonism predates cognitive impairment by greater than 1 year. 57. St. John's wort is an inducer of 450 Cyprus pound. Avoid an SSRI, SNRI. 58. A spiral fracture occurs in response to a twisting force on the bone. Highly specific for child abuse if seen in a child with a suspicious history and questions anyways. In real life it seems a little more controversial. 59. Cocaine inhibits the reuptake of norepinephrine, causing alpha and beta adrenergic stimulation. Treatment. Benzodiazepines reduce anxiety, agitation. Beta blockers CI should be treated with aspirin, nitrates, CCB, but beta blockers are contraindicated. 60. What is the likely etiology of erectile dysfunction in a middle-aged man that complains of difficulty attaining, maintaining an erection during sexual activity for 6 months? He continues to have normal early morning penile erections. Psychogenic persistence of nocturnal and early morning erections indicates intact vascular and nerve function in the penis. 61. What is the first-line treatment for generalized anxiety disorder GAD? CBT greater than SSRIs, SNRIs, buspirone. Second-line treatments include benzodiazepines and buspirone. Some sources say first, some say second line. 62. Blockage of which dopamine pathway is responsible for extrapyramidal symptoms in patients taking antipsychotics? Nigrostriatal pathway, for example, acute dystonia, akathisia, Parkinsonism, MA, NETH, for example, nigrostriatal extrapyramidal. 63. What pharmacotherapeutic medications may be used to treat neuroleptic malignant syndrome? Dantrolene or dopamine agonists, for example. Bromocriptine, however, discontinuation of the causative agent is the most critical intervention, as well as intensive supportive care. 69. What is the recommended maintenance treatment for a patient with a history of kidney disease that presents with bipolar I disorder? Valproate, lithium, and valproate are first-line treatments. However, lithium has potential nephrotoxic effects. Other effective treatment options include quetiapine and lamotrigine. 73. What is the first-line treatment for major depressive disorder? CBT plus SSRIs. 74. Bupropion may be used for smoking cessation, but is contraindicated in patients with bulimia, anorexia, or seizures due to its seizure threshold lowering adverse effect. 76. What is the likely diagnosis in a teenage boy that presents after having an episode of unconsciousness followed by drowsiness and headache? The symptoms resolved within 1 hour. Physical exam is significant for a mild rash around the patient's mouth. Routine toxicology screen is negative. Inhalant abuse, for example, glue, toluene, and perioral skin changes. Blue sniffer's rash is classic. Chronic abuse of nitrous oxide is associated with vitamin B12 deficiency and may cause polyneuropathy. 78. Patients with a single episode of major depressive disorder should continue antidepressants for an additional 6 months following the acute response to decrease risk of relapse, versus patients with recurrent, chronic, or severe episodes, which require treatment for an additional 1 to 3 years or indefinitely. 79. Rapid diagnosis, patient being treated for hallucinations admitted with fever plus confusion. Exam shows diffuse muscle resistance to motion, diaphoresis, tachypnea, dry mucous membranes. Neuroleptic malignant syndrome due to antipsychotics. Diffuse muscular rigidity shows resistance to motion, lead pipe rigidity. NMS, not all there, muscle rigidity, sweating, autonomic instability. Serotonin syndrome is similar to NMS but will also have shivering, hyperreflexia, myoclonus, ataxia. 80. DSM-5 diagnostic criteria for schizophrenia. 2 of the following symptoms must be present during a significant portion of the time during a 1-month period, with at least one symptom being either delusions, hallucinations, disorganized speech, or negative symptoms. Delusions, fixed beliefs that are not in line with reality. Hallucinations, experiencing things that are not real. Disorganized speech, difficulty communicating or making sense when speaking. Negative symptoms, loss of motivation, lack of emotion, or lack of ability to experience pleasure. Social, occupational dysfunction, For a significant portion of the time period, the individual's ability to function in social or occupational settings is significantly impaired as a result of their symptoms. Duration. Symptoms must have been present for at least 6 months, including at least 1 month of active phase symptoms. Schizoaffective disorder, depressive or bipolar disorder with psychotic features, and substance, medication-induced psychotic disorder have been ruled out as the primary explanation for the symptoms. If there is a history of autism spectrum disorder or a communication disorder of childhood onset, the additional diagnosis of schizophrenia is made only if prominent delusions or hallucinations are also present for at least a month. 82. What psychiatric disorder is characterized by the persistent and intense desire to be the opposite sex, which causes significant distress. Gender dysphoria. 83. An adequate antidepressant trial is generally considered to be at least 4 to 6 weeks at a therapeutic dosage. If patient symptoms are not relieved after 4 to 6 weeks, then switching to another first-line antidepressant is warranted. 84. Which antidepressant is associated with priapism? Trazodone. 85. The best initial pharmacological therapy for peripheral neuropathy is pregabalin or gabapentin. Treatment includes optimal glycemic control once established. It cannot reverse diabetic neuropathy. Options include pregabalin first choice, amitriptyline TCA, and venlafaxine, duloxetine SNRI. 86. Illness anxiety disorder is a preoccupation with having undiagnosed illness, often with none or mild somatic symptoms. Differential diagnosis with somatic symptom disorder, which is anxiety due to physical somatic symptoms. 87. A person with antisocial personality disorder will have evidence of conduct disorder before 15 years old. 88. Oppositional defiant disorder is a childhood disorder characterized by an enduring pattern of hostile, defiant behavior towards authority figures in the absence of serious violations of societal norms for greater than 6 months. 89. What is the recommended treatment for oppositional defiant disorder? Psychotherapy and parent management training. 90. Increased sensitivity to lactate infusion is associated with panic attacks. Amygdala in brain responds to low pH and helps control our response to fear, so lactic acid infusion would make sense that it would induce panic attack. 91. What is the treatment of opioid withdrawal? Methadone or buprenorphine opioid agonist. 92. What are the 3 Cs of tricyclic antidepressant toxicity? Convulsions, coma, cardiotoxicity. Long QT, QRS treatment. Sodium bicarbonate for cardiotoxicity. Increased plasma pH favors an active form of TCA. Increased pH decreases drug avidity for sodium channels. 93. What is the first-line pharmacologic treatment for obsessive-compulsive disorder OCD? SSRIs, for example, sertraline. Note, also may use clomipramine and venlafaxine SSRIs, sertraline, fluoxetine, fluvoxamine, and paroxetine. 94. Rapid diagnosis, women with recurrent thoughts causing distress. She has palpitations and tremors and gets up 30 times per night to check the door and windows. She acknowledges these aren't normal. OCD, obsessions recurring and intrusive thoughts plus compulsions, repetitive actions that provide relief from anxiety. 95. Reactive attachment disorder and disinhibited social engagement disorder are both due to abuse and neglect. The difference is that RAD has withdrawn behavior while DSED will have disinhibition over familiarity with strangers. DSM-5 criteria for RAD is lesser than 5 years old and consistent pattern of inhibited, withdrawn behavior towards caretakers, minimal emotional expression to others, and inadequate care treatment, behavior modification of caretakers. 97. Prevalence for schizophrenia is higher in urban areas. Rural areas have a tighter family unit and more support. Higher incidence in babies born in winter, early spring. 98. 79-year-old female complains of decreased total sleep time, earlier onset of sleep, nocturnal awakenings, reduced sleep during early morning hours, and daytime napping. What is the most appropriate intervention? Reassurance. These are consistent with aging and no further workup is necessary if there is no significant impairment in activities of daily living or cognition. 99. What is the recommended management in a schizophrenia patient with poor compliance? Long-acting depot injections of typical antipsychotics. 100. What is the choice of long-term treatment in a patient with bipolar disorder with a history of lupus, MDD, and a creatinine level of 1.6? Valproate, lifelong maintenance therapy with mood stabilizers, is indicated after the manic episode with severe, recurrent symptoms in patients with BPD. Drugs of choice are lithium and valproate. In patients with renal dysfunction probably due to lupus nephritis, the use of lithium is contraindicated. 101. The SPIKES protocol is an evidence-based protocol used for delivering serious news. It includes the following steps. 1. Create appropriate setting. 2. Address patient's perception. 3. Seek patient's invitation. 4. Give knowledge to the patient about diagnosis and prognosis. 5. Address the patient's emotions. 6. Provide strategy and summary. 102. MAO inhibitors phenelzine are second-line treatment for atypical depression but are contraindicated in patients taking SSRIs due to the risk of serotonin syndrome. Antidepressants should be discontinued at least 2 weeks before initiating MAOIs. Fluoxetine should be discontinued at least 5 weeks before initiating MAOIs due to risk of serotonin syndrome. 103. Is functioning impaired in patients with delusional disorder? No behavior is not obviously bizarre or odd. Common themes are grandiosity, jealous, and persecution. 104. A schizophrenic patient is given a dose of haloperidol and presents later to the nurse's station with sustained contraction of his neck to the right. Where are the possible treatments? Benztropine and H1 antagonist diphenhydramine. Acute dystonia occurs hours to days after antipsychotic administration. Both drugs have anticholinergic activity. 106. A 17-year-old teenager with active suicidal ideation must be hospitalized for safety and the parents must be informed. Is parental consent required? It is ideal, but not required. 107. Avoidant personality disorder and dependent personality disorder both cling to relationships, but avoidant personality disorder are slow to get involved. Dependent personality disorder actively and aggressively seek relationships. 108. Dependent personality disorder usually have long-lasting relationships with one person, while borderline and histrionic personality disorder are unable to maintain a long-lasting relationship. 109. What type of defense is seen in a clinician who believes that a patient dislikes him, when in actuality he dislikes the patient? Projection. 110. What type of defense is seen with a man who punches a wall after an argument with a colleague rather than telling the colleague his true feelings? Displacement. 111. What type of defense is seen in a patient who recalls a traumatic event without showing any emotion? Isolation of affect. 112. What type of defense is seen in someone who suppresses feelings of fear associated with the sight of blood during surgery in order to provide necessary patient care? Suppression. 113. What type of defense is seen with a student who uses feelings of anger to motivate himself to study for an exam in order to spite someone? Sublimation. 114. What is the treatment of choice in a patient with elevated LFTs and alcohol withdrawal? Lorazepam. Lorazepam is also treatment of choice in inpatient setting. Long-acting benzodiazepines diazepam, chlorodiazepoxide should be avoided as they are metabolized by the liver. 115. Methylphenidate is the first-line therapy for ADHD but should not be used in patients lesser than 6 years of age. Behavioral therapy is first-line therapy for preschool-age children and adjunct therapies for school-age children and adults. 117. Aripiprazole and quetiapine are atypical antipsychotics that are the least likely to produce hyperprolactinemia. 118. A patient with a history of schizophrenia develops subjective restlessness and an inability to sit still. In addition to reducing the antipsychotic dosage, pharmacotherapy can include beta blockers, benzodiazepine, or benztropine. Propranolol is a common initial choice off-label use. Reduce dose before discontinuing. Only discontinue if reduction doesn't help. 119. What type of defense mechanism is seen in a patient who is newly diagnosed with pancreatic cancer who responds to his diagnosis by working more and spending several hours analyzing his own labs and researching new treatment regimens? Intellectualization. Patient is attempting to avoid anxiety by focusing on the non-emotional aspects of his cancer diagnosis. 120. Obstetric complications, hypoxia, hemorrhage, infection, preterm labor have been identified as an environmental risk factor for the later development of schizophrenia. Also urban areas, birth in late winter, early spring, and advanced paternal age urban areas is most likely due to loss of family structure and instability versus rural areas that usually have more family support. 121. What is the treatment of choice in treating depressive symptoms in terminally ill adults with a short lifespan? Psychostimulants, for example, methylphenidate patient can undergo ECT, but this is a fast-acting response and beneficial in terminally ill patients with severe depression. 122. Adjustment disorder is a response to a stressor that must begin within 3 months of the stressor and last lesser than 6 months following termination of the stressor. 124. Is label indifference required for the diagnosis of conversion disorder? No, the term conversion comes from the idea that the brain somehow converts psychological distress into neurological symptoms. Unlike in somatic symptom disorder, patients with conversion disorder are typically calm and unconcerned when describing their symptoms. This is classically referred to as label indifference. However, this sign is not specific or sensitive and was removed as a diagnostic criteria from DSM-5. 125. Delayed sleep phase disorder is a subtype of circadian rhythm sleep-wake disorders characterized by recurrent delay in sleep onset and waking times. For example, a night owl. 126. What neurological abnormalities are present in acute intermittent porphyria? Polyneuropathy and psychotic abnormalities, hallucinations, anxiety, insomnia. 127. Parotitis is a finding in patients with bulimia nervosa, which may show an elevated amylase. Potassium, sodium, chlorine, and calcium will all be decreased. 128. What is the risk of developing schizophrenia in monozygotic twins? 50% about 10 if first degree, relative about 40% if both parents are affected. 129. What are the weight-neutral atypical antipsychotics? Aripiprazole and risperidone. 130. What pharmacotherapy can be used to treat adjustment disorder? Benzodiazepines, zolpidem for anxiety and insomnia, SSRIs for depressed mood. Important CBT and psychodynamic psychotherapy are first-line treatments. 131. What is the first-line treatment for delusional disorder? Antipsychotics. An antipsychotic agent with as few side effects as possible. Aripiprazole or ziprasidone should be used. Gain a therapeutic alliance as patients are often suspicious of the clinician's motives. 132. What is the best choice of pharmacotherapy for a patient who develops severe anxiety before giving speeches? Patient's past medical history is notable for asthma. Benzodiazepine. Beta blockers are first-choice pharmacotherapy but are contraindicated in asthma. 133. What is first-line pharmacotherapy for somatic symptom disorder? SSRI. First line is to regularly schedule visits and promote stress reduction. If that does not work, CBT and a trial of antidepressant medications SSRIs are warranted. 134. What is the most likely diagnosis in a patient who becomes agitated and confused shortly after taking his medications? Past medical history includes mild neurocognitive disorder, BPH, and anxiety. Medications include terazosin and alprazolam. Paradoxical agitation secondary to benzodiazepines characterized by increased agitation, confusion, aggression, and disinhibition, typically within an hour of administration. 135. What is the drug of choice in a bipolar patient who wishes to become pregnant? Lamotrigine has a favorable reproductive safety profile. Treating during pregnancy is tricky because it depends on the severity. If possible, avoid it during the first semester. If not, lamotrigine is the drug of choice. Emergencies. What are the risk factors for suicidal behavior? Risk factors for suicidal behavior include previous suicide attempt, psychiatric conditions such as schizophrenia, mood disorders, alcohol or substance use disorder, eating disorders, social factors such as unemployment and low socioeconomic status, and personal factors such as male sex and possession of firearms. What are the clinical features of suicidal behavior? The clinical features of suicidal behavior include suicidal ideation, concrete intent and plans, underlying conditions, and previous suicide attempts. How is suicidal behavior managed? For imminent risk, hospitalization may be necessary, even against the patient's will. For elevated risk, measures to increase the patient's social contacts and interaction with medical professionals are taken. Long-term management includes treatment of underlying psychiatric disorders, counseling, and assistance in improving the patient's social circumstances and development of problem-solving and coping skills. What is neuroleptic malignant syndrome? Neuroleptic malignant syndrome is a rare but potentially fatal adverse effect of antipsychotic drugs, characterized by muscle rigidity, akinesia, tremor, autonomic instability, hyperthermia, altered mental status, high levels of creatine kinase, and metabolic acidosis. How is neuroleptic malignant syndrome treated? Neuroleptic malignant syndrome is treated with pharmacotherapy, such as dantrolene and benzodiazepines. Alternatives include bromocriptine, apomorphine, or amantadine. What is lithium toxicity? Lithium toxicity is a condition that occurs when there are elevated lithium concentrations in the body, which can be caused by overdose, renal impairment, low effective circulating volume, and concomitant medication use that increases renal absorption of lithium. Symptoms include gastrointestinal upset, neuromuscular excitability, altered mental status, and acute renal failure. How is lithium toxicity treated? Lithium toxicity is treated by discontinuation of lithium, hydration with isotonic fluid, and hemodialysis or ventilatory support if required for severe cases. What is malignant catatonia? Malignant catatonia is a serious neuropsychiatric condition associated with schizophrenia, thought to be caused by neurotransmitter dysregulation. Symptoms include autonomic dysregulation, movement impairment, altered mental status, and fever. How is malignant catatonia treated? Malignant catatonia is treated by discontinuation of dopamine-blocking drugs, benzodiazepines, and electroconvulsive therapy. What is serotonin syndrome? Serotonin syndrome is a potentially life-threatening condition caused by excessive serotonin activity in the brain, which can be caused by the use of certain psychiatric drugs, other drugs, and increased risk under certain conditions such as concurrent use of 2 or more serotonergic drugs or switching from one serotonergic drug to another without tapering. Symptoms include neuromuscular excitability, autonomic dysfunction, gastrointestinal upset, and altered mental status. How is serotonin syndrome treated? Serotonin syndrome is treated with supportive care, such as ciproheptadine, antihypertensives, fluid replacement, and benzodiazepines. What is delirium tremens? Delirium tremens is a severe form of alcohol withdrawal characterized by altered mental status, visual and tactile hallucinations, impaired consciousness, anxiety, disorganized thinking, increased suggestibility, psychomotor agitation, and fidgeting. How is delirium tremens treated? Delirium tremens is treated with benzodiazepines as a first-line treatment. Shorter or intermediate-acting benzodiazepines such as oxazepam or lorazepam are considered in patients with a slow metabolism, such as the elderly or those with liver failure. Longer-acting benzodiazepines such as chlorodiazepam or diazepam are preferred in all other patients. Second-line treatment is anticonvulsants in case of contraindications for benzodiazepines. What is delirium? Delirium is a serious condition characterized by an acute onset of confusion and changes in attention and perception. It is most common in pediatric, elderly, and hospitalized patients, and is often associated with metabolic conditions, infections, trauma, CNS pathologies, hypoxia, acute cardiovascular disease, drug and toxin exposure, alcohol and illicit substance intoxication or withdrawal, and ongoing symptoms. How is delirium treated? Delirium is treated by addressing the underlying cause, maintaining adequate hydration, and reducing confusion through reorientation to time, place, and person. What is acute dystonia? Acute dystonia is a movement disorder caused by inhibition of the nigrostriatal dopaminergic pathways, which can occur as a side effect of antipsychotic drugs. Symptoms include muscle spasms, stiffness, torticollis, oculogeric crisis, and laryngospasm. How is acute dystonia treated? Acute dystonia is treated with drugs such as benztropine, diphenhydramine, or benzodiazepines. In cases of laryngospasm, intubation may be necessary. What is tyramine-induced hypertensive crisis? Tyramine-induced hypertensive crisis is a condition caused by the consumption of tyramine-rich foods or beverages, which can stimulate the sympathetic nervous system and cause a hypertensive crisis. How is tyramine-induced hypertensive crisis treated? Tyramine-induced hypertensive crisis is usually self-limiting and rapid blood pressure reduction is contraindicated. What is tricyclic antidepressant toxicity? Tricyclic antidepressant toxicity is a condition caused by the ingestion of tricyclic antidepressants, which can cause various effects such as anticholinergic effects, hyperpyrexia, prolonged QTc interval, arrhythmias, seizures, coma, and respiratory depression. How is tricyclic antidepressant toxicity treated? Tricyclic antidepressant toxicity is treated with supportive care and decontamination measures, such as gastric lavage or activated charcoal. Cardiac and respiratory support may also be necessary. How are extrapyramidal symptoms treated? The treatment for EPS varies depending on the specific subtype. For acute dystonia, treatment options include anticholinergics such as benztropine, antihistamines like diphenhydramine, and benzodiazepines. Additionally, switching to an antipsychotic drug with a lower risk of EPS, known as a second-generation antipsychotics, or continuing secondary prophylaxis with benztropine may be recommended. For pseudoparkinsonism, the preferred treatment is to lower the dose or switch to an SGA. If this is not possible or not tolerated, anticholinergics like benztropine or dopamine agonists like amantadine may be used. Akathisia treatment often starts with lowering the dose or switching to an SGA. If this is not effective, beta blockers such as propranolol may be used as a first-line treatment, and benzodiazepines like clonazepam as a second-line treatment. Tardive dyskinesia treatment usually involves consulting a psychiatrist and discontinuing the causative drug, if possible, after slowly tapering the dose. Switching to an SGA, especially clozapine and quetiapine, may be recommended. Additionally, vesicular monoamine transporter 2 inhibitors such as valbenazine, deutetrabenazine, and tetrabenazine may be used for moderate or severe symptoms. What is the management of antipsychotic adverse effects for patients with comorbidities? The management of antipsychotic adverse effects includes several different strategies depending on the specific side effect. For movement disorders, the recommended approach is to use the lowest possible dose of antipsychotics and consider switching to another agent. Additionally, an anticholinergic or benzodiazepine may be started to help manage the symptoms. For hyperprolactinemia, switching to an antipsychotic with a lower risk of this side effect, such as aripiprazole or ziprasidone, or starting bromocriptine may be considered. Obesity can be managed by providing diet and exercise advice and potentially switching to an antipsychotic with fewer metabolic effects, such as aripiprazole or starting metformin. For diabetes, treatment does not vary from standard diabetes management. Orthostatic hypotension can be managed by dividing doses, reducing the speed of titration, advising patients to avoid sudden changes in position, and consider fludrocortisone. Hyperlipidemia can be managed by starting lipid-lowering agents. Neutropenia is managed differently depending on the severity of the condition. In cases of mild or moderate neutropenia, clozapine can be continued at increased screening intervals, while in severe cases, clozapine should be stopped and hematology should be consulted. Treating any associated infections and considering granulocyte colony stimulating factor may also be considered. What are the indications for antipsychotics? Antipsychotics are used for a variety of indications, including acute psychosis, bipolar affective disorder or acute mania, delirium, delusional or agitated states, psychosis during pregnancy, postpartum psychosis, and schizophrenia and other chronic psychotic disorders. What are the preferred agents for acute therapy? For acute psychosis, first-line agents are second-generation antipsychotics such as aripiprazole for acute delusions and risperidone for acute mania or hypomania. High-potency antipsychotics, such as haloperidol, can also be used as an alternative. For bipolar affective disorder or acute mania, high-potency antipsychotics are preferred. For delirium, high-potency antipsychotics or low-potency antipsychotics can be used. For delusional or agitated states, high-potency antipsychotics are used. Children and adolescents are treated with risperidone, while the elderly are treated with risperidone or melpirone. For psychotic symptoms caused by medication for Parkinson's disease, clozapine is used. For psychosis during pregnancy, first-line agents are first-generation antipsychotics, such as haloperidol. For postpartum psychosis, first-line agents are SGAS such as quetiapine, risperidone, and olanzapine. What are the preferred agents for long-term therapy? For schizophrenia and other chronic psychotic disorders, SGAS are effective for positive and negative symptoms. In cases of treatment failure, switch to high-potency antipsychotics primarily effective for positive symptoms or clozapine. For concomitant medication for patients with obsessive-compulsive disorders, SGAS are preferred. For treatment-resistant schizophrenia and schizophrenia associated with persistent suicidality, clozapine is used. For tic disorders, Tourette syndrome, and Huntington disease, tiopride is used. To reduce or avoid anticholinergic side effects in patients of advanced age, high-potency substances, such as haloperidol, risperidone, or melpirone are preferred. Is there any difference in the clinical effectiveness of antipsychotics? All antipsychotics, except for clozapine, used for treatment-resistant schizophrenia, have similar clinical effectiveness. The choice of drug depends on the side effect profile of the antipsychotic drugs and the patient's clinical status. Second-generation antipsychotics are preferred in many cases because they carry a lower risk of extrapyramidal side effects. However, in some patients, for example, those with significant metabolic risk factors, first-generation antipsychotics may be more suitable. What are the different sleep phases? The different sleep phases include awake and REM sleep, stage N1, stage N2, stage N3, and REM sleep. What are the characteristics of the awake phase? During the awake phase, the person is alert and the electroencephalogram shows beta waves with the lowest amplitude. Circadian rhythm sleep-wake disorders and insomnia disorder are sleep phase-specific disorders that can occur during this phase. What are the characteristics of NREM sleep? NREM sleep is divided into 3 stages, stage N1, stage N2, and stage N3. Stage N1 is the lightest stage of sleep and is characterized by hypnic jerks and theta waves. Stage N2 is deeper sleep compared to stage N1 and is characterized by sleep spindles and K-complexes. Stage N3 is the slow wave sleep, the deepest sleep, and is characterized by delta waves. What are the characteristics of REM sleep? REM sleep is characterized by high dream activity, high waking threshold, irregular, sharply peaked eye movements, maximum muscle relaxation, increased heart rate, meiosis, and nocturnal penile, clitoral tumescence. The percentage of REM sleep decreases with age and the duration of REM sleep increases over the course of the night. REM sleep latency is the period of time between the onset of sleep and the first REM episode and typically lasts 90 to 120 minutes in a healthy person. What are some disorders that can occur during specific sleep phases? During the awake phase, disorders such as circadian rhythm sleep-wake disorders and insomnia disorder can occur. During NREM sleep, obstructive sleep apnea and teeth grinding can occur. During REM sleep, nightmare disorder and REM sleep behavior disorder can occur. What is dysomnia? Dysomnia is a group of primary sleeping disorders characterized by difficulty falling, staying asleep or hypersomnia, excessive daytime sleepiness. What are the different types of dysomnias? The different types of dysomnias include circadian rhythm sleep-wake disorder, delayed sleep phase disorder, advanced sleep phase disorder, jet lag disorder, shift work disorder, non-24-hour sleep-wake disorder, insomnia disorder, hypersomnolence disorder, narcolepsy, central sleep apnea, obstructive sleep apnea. What is a parasomnia? Parasomnia is a group of primary sleeping disorders characterized by abnormal behaviors or experiences that occur while falling asleep, during sleep, or while waking up. What are the different types of parasomnias? The different types of parasomnias include NREM-related parasomnia, sleepwalking disorder, sleep terror disorder, and REM-related parasomnia, nightmare disorder, REM sleep behavior disorder, recurrent isolated sleep paralysis, restless legs syndrome. What are the common features of circadian rhythm sleep-wake disorders? Common features of circadian rhythm sleep-wake disorders include insomnia, excessive daytime somnolence, irritability, frequent waking during abnormal hours, headaches, and impaired concentration. What is delayed sleep phase disorder? Delayed sleep phase disorder is a sleep-wake disorder characterized by a recurrent delay in sleep onset and waking times. Risk factors include puberty, use of stimulants, and irregular sleep. Treatment options include phototherapy in the morning, melatonin receptor agonist, and chronotherapy. What is advanced sleep phase disorder? This disorder is associated with older age. Treatment options include reassurance and phototherapy in the evening. What is jet lag disorder? Jet lag disorder is a circadian rhythm sleep disorder characterized by insomnia or hypersomnia due to travel across time zones. Risk factors include sleep deprivation prior to travel. Treatment options include exposure to sunlight in the new time zone to accelerate recovery as it resolves spontaneously. What is shift work disorder? Shift work disorder is a sleep-wake disorder characterized by misaligned circadian rhythm due to nightly working hours and sleep deprivation. Risk factors include shifts longer than 16 hours or night shifts. Treatment options include modafinil if severe and bright light therapy at night to adapt to the work shift. What is non-24-hour sleep-wake disorder? Non-24-hour sleep-wake disorder is a circadian rhythm sleep disorder characterized by an individual's inability to align with the environmental 24-hour rhythm. Risk factors include blindness and impaired light sensitivity. Treatment options include a combination of phototherapy and scototherapy for the resynchronization of the patient's circadian rhythm and melatonin receptor agonist. What is a personality disorder? A personality disorder is a pervasive, inflexible, and maladaptive personality pattern that leads to significant distress or functional impairment. When do personality disorders usually develop? Personality disorders usually develop in late childhood or adolescence. Are there any gender differences in the prevalence of personality disorders? Antisocial and narcissistic personality disorders are more commonly diagnosed in males, while histrionic and borderline personality disorders are more commonly diagnosed in females. What causes personality disorders? The causes of personality disorders are multifactorial and include a combination of hereditary factors, for example, personality disorders in parents, and psychosocial factors like child neglect, abuse. How are personality disorders classified according to the DSM-5? The DSM-5 divides personality disorders into 3 clusters. Cluster A includes paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. Cluster B includes antisocial personality disorder, borderline personality disorder, histrionic personality disorder, and narcissistic personality disorder. Cluster C includes avoidant personality disorder, dependent personality disorder, and obsessive-compulsive personality disorder. What are the common features of all personality disorders? The common features of all personality disorders include that affected individuals consider their symptoms normal and non-problematic. Thinking and behavior that significantly differ from cultural expectations. Diagnostic criteria that include at least 2 or more of the following deviating significantly from cultural expectations. Cognition, affectivity, interpersonal functioning, impulse control, beginning in early adulthood and remaining stable over time, leading to significant distress and impaired functioning in important areas of life, and not being caused by another mental disorder, substance abuse, or other medical condition. What are the treatment options for personality disorders? Treatment options for personality disorders include psychotherapy, dialectical behavior therapy, group therapy, and/or cognitive therapy, symptomatic medical therapy, mood stabilizers, antipsychotics, and antidepressants. What is anorexia nervosa? Anorexia nervosa is an eating disorder characterized by a fear of weight gain, body image disturbance, and a significant deliberate reduction in body mass through restrictive eating, excessive exercise, and purging. Individuals with anorexia nervosa have a body mass index less than 18.5 kilograms divided by M2. What is the epidemiology of anorexia nervosa? Anorexia nervosa is more common in females than males, with a ratio of 10 to 1. What are the causes of anorexia nervosa? The causes of anorexia nervosa are multifactorial and not entirely understood. They include genetic factors, psychiatric comorbidities such as OCD and anxiety disorders, alterations in the endogenous reward system, and psychosocial factors such as high-pressure careers and sports. What is bulimia nervosa? Bulimia nervosa is an eating disorder characterized by recurrent binge eating, followed by compulsive behavior to counteract weight gain. This behavior includes self-induced vomiting, laxative abuse, and transient starvation periods. Individuals with bulimia nervosa have a normal or slightly elevated body mass index of at least 18.5 kilograms divided by M2. What is the etiology of bulimia nervosa? The etiology of bulimia nervosa is multifactorial and not entirely understood. Factors associated with the disorder include genetic factors, psychiatric comorbidities, alterations in the endogenous reward system, psychosocial factors, and obesity during childhood and early puberty. What are the treatment options for anorexia nervosa and bulimia nervosa? The treatment options for anorexia nervosa and bulimia nervosa include psychotherapy, cognitive behavioral therapy, and pharmacotherapy. In severe cases, antidepressants such as SSRIs and mirtazapine and olanzapine may be used. Nutritional support for healthy eating habits, and educational support for nutrition are also important for treatment. In case of BMI lesser than 15 kilograms divided by M2, hospitalization may be necessary for anorexia nervosa.